Hello, everybody. My name is Professor Raffaele Califano. I'm a medical oncologist at the Christie and Manchester University Hospital in Manchester in the UK. I'm joined today by Professor Holle, who is an oncology pharmacist and professor of clinical pharmacology at the University of Connecticut and USF Health in the United States, and also joined by Professor Stenzinger, who is a pathologist and professor of molecular tumor pathology at Heidelberg University in Heidelberg, Germany. In this section, we will discuss the current first-line standard of care immunotherapy landscape and also the unmet needs for patients with metastatic non-small cell lung cancer without driver mutation. It is pretty clear that over the last few years, a number of treatment options have now been approved in the clinical practice in the first-line space. And I would like to ask Professor Holle to comment on the potential options that we have, from an American point of view, but also from a European point of view, please.
Great. Thank you very much. Well, we know that first-line therapy in the metastatic setting for non-small cell lung cancer without actionable mutations really lends itself to using immunotherapy. And we have guidelines in the United States called the National Comprehensive Cancer Network Guidelines. And then in the European setting, the European Society for Medical Oncology guidelines. And both guidelines really offer immunotherapy as a first-line option, particularly monotherapy in patients who have a high expression of PD-L1, so 50% or greater. And we're talking about also in patients who have a good performance status, because these patients need to be able to be functioning well, to be able to tolerate therapy and have a good effect. And then when patients who have a lower PD-L1 expression, so less than 50% by the ESMO guidelines, and NCCN guidelines uses 1 to 49%, and still a good performance status, you can combine immunotherapy with chemotherapy or do a dual immunotherapy combination. In those with less than 1% PDL expression, those patients may not do as well with immunotherapy. We can talk a little bit more about specifics of drugs. But in the NCCN guidelines in the United States, we recommend using chemotherapy in that population. So overall, our guidelines are very similar between the two organizations, but immunotherapy is a standard of care now in the metastatic setting in those patients without mutations. I thought, Dr. Califano, if you could talk a little bit more about some of the data supporting those immunotherapy options, that would be helpful.
And all these phase 3 randomized clinical trials have clearly shown that with immunotherapy-based strategy, you have a higher response rate, almost double than what you would expect with chemotherapy. The response rates are now in the range of 45 to 50%. But there's also a clear impact on overall survival, not only as a median overall survival. We see now a number of patients surviving longer than 3 years. And for example, recent 5 years follow-up data from the chemoimmunotherapy studies with pembrolizumab, for example, have shown that approximately 20% of patients who were in the chemoimmunotherapy arm will still be alive at 5 years, which is unprecedented if you think that we are discussing about advanced non-small cell lung cancer without an oncogenic driver. On the other hand, though, as a matter of fact, 20 to 30% of the patients will progress through their first-line immunotherapy-based strategy, and these are patients with primary resistance. And I believe there's an unmet need to either select in a better way patients for the right strategy, but also there's an unmet need in finding alternative therapeutic strategies to try and improve the outcomes for our patients. I would like to ask from a pathology perspective to Professor Stenzinger, what can we use to select patients most likely to benefit from these immunotherapy strategies, and including some immunostains, but also the potential role of molecular testing with next generation sequencing?
Thank you. That's an excellent question. I think if you look across, solid tumor types beyond non-small cell lung cancer, there are, 3 different biomarkers currently approved, at least in the United States, which is the MSI status, MSI high / dMMR, then TMB as one of these genomic biomarkers, and as a third biomarker, PD-L1 immunohistochemistry. Now, if you focus and narrow in a little bit on non-small cell lung cancer, I think it's fair to say, given that the prevalence of microsatellite instability is very, very low, that it's really only PD-L1 immunohistochemistry that does play a role in that context. You have to be, careful in terms of the different antibody clones from an immunohistochemistry standpoint, that you need to factor them in, and also that you are familiar with the different cut points and more particularly the different scoring systems that are out there. So the tumor proportion score, for example, plays a predominant role, but there are also other scores like the IC score, depending on the treatment, obviously, and the line of therapy. The other major pillar is really the exclusion of major drivers. So that's probably one thing really to keep in mind. So testing of, for example, ALK gene fusions is very critical, because we do know that these patients, so tumors harboring these gene fusions, do not respond very well to immunotherapy, more specifically immune checkpoint blockade. So maybe these are, to me, the two major aspects, and that clearly also shows you that we still have some work to do in terms of how to actually mirror the complexity of the tumor host or tumor immune cell interaction on a biomarker side more precisely than we are doing right now.
Thank you very much. And I think you've touched on a very relevant point from a clinical practice point of view, is the need to have your molecular results, including PD-L1, but also EGFR, ALK, ROS1, BRAF, MET, for example, before you plan your strategy. And this is very important, in particular, if you have a patient with a light smoking history or are never smokers, because what you don't want to do is to make the mistake of starting patients on immunotherapy, single agent, for example, just on the basis of a high PD-L1 expression, and then 3 weeks later, the tumor harbors an EGFR activated mutation. You're doing a major disservice to your patients if you started someone on immunotherapy, on the basis of a high PD-L1 expression, whilst on the other hand, there is an oncogenic driver, and that's what is driving the tumor and needs to be addressed. So thank you for touching on that. And this is very clear in US-based and EU-based guidelines that when possible, you should get the results of your molecular testing in a timely fashion before you plan your first-line treatment. And Professor Holle, I don't know, from a clinical point of view, do we have any clinical characteristics that will make you think I should choose combination strategies compared to single agent strategies?
Well, I think sometimes it also depends upon the patient's performance status, as I mentioned when we were talking about the guidelines. The combination strategies will have more toxicity associated with them. So those patients who have a better performance status are more likely to do well on a combination therapy. The toxicity profile differs as well. I think those are all really important factors. So speaking of toxicity, I think we know that the combination or dual checkpoint inhibitors have a higher incidence of immune-related adverse events than single-agent immunotherapy agents. The immune therapy toxicity is much different than what we think of with traditional cytotoxic chemotherapy. It can affect essentially any organ, causing an autoimmune-like response. And we do know that the incidence of grade 3 and 4 immune-related adverse events can actually be associated with a higher overall survival rate than those who don't have those. So although we don't want our patients to experience high-grade toxicity and have to potentially stop therapy, there may be some benefit in those patients who do have those toxicities. So that is an interesting sort of conundrum you can be in when you're treating patients as well.
And thanks for touching on that, because as a clinician, when you mention to the person in front of you that unfortunately you have to stop their active treatment due to safety reasons, understandably, the patient will be quite upset and concerned about losing that safety net, which was for them that regular 3-weekly, 4-weekly, or 6-weekly regimen. There is retrospective data to suggest that patients who have to discontinue an immunotherapy-based combination due to, or strategy I should say, due to high-grade immune-related adverse events, despite discontinuing the infusions, they may still derive a long-term benefit, because realistically, once the immune system is primed, you may have a carryover effect. So I do use that piece of information, albeit retrospective, to sort of reassure the patients that the treatment may still continue to work, and there is a number of case reports or series to support that, even if the drug has been discontinued. So thank you very much. I think we've had a very good discussion around these clinical points. I would like to thank the faculty for their input, and you can find out about more immunotherapeutic approaches for the treatment of advanced non-small cell lung cancer without an oncogenic driver mutation in other short videos on this activity. Thank you.
Hello, my name is Albrecht Stenzinger. I'm a pathologist and molecular pathologist, and also professor of molecular tumor pathology at Heidelberg University in Heidelberg, Germany. And I'm joined today by Professor Raffaele Califano, a medical oncologist at the Christie and Manchester University Hospital in the United Kingdom. And in this section, we will discuss prognostic and also predictive biomarkers for immunotherapy in patients with metastatic non-small cell lung cancer without driver mutations. Now, I think, looking at the overall landscape from a clinical perspective, what are your tools, Dr. Califano, that you are currently requesting when it comes to selection of patients for immunotherapy?
Thank you. From a clinical point of view, I will request all the molecular markers as per international recommendations. So all histologies will be tested for PD-L1 expression using immunohistochemistry, and then for non-squamous histology and some select patients with squamous histology, I will request next-generation sequencing evaluating biomarkers such as EGFR, ALK, ROS1, BRAF, MET, RET, and TRAC, and so on. And I believe when you're at the point of planning first-line treatment, if patient's condition allows, you should have all this information in front of you in order to decide what's the best strategy, because it's clear that even if you have a very high PD-L1 expression in the tumor biopsy, but the tumor also harbors an oncogenic driver that you can target with approved drugs in the first-line setting, the driver will need to be addressed first. And that's very important to make sure that you're giving your patients the appropriate treatment.
Thank you for the very clear statement. So you are saying you need a kind of, if you will, one-stop shop that offers you the full molecular makeup of the tumor to make the appropriate decision in terms of patient management.
Yes, and obviously in a clinical setting, there would be turnaround times, and PD-L1 expression, as you know very well, is an immunohistochemistry test, and it will be ready in a very, very short period of time, whilst next-generation sequencing may take 1 or 2 business weeks, and also it depends if the test is run in-house or needs to be outsourced, and there will be some operational delays in order to get the sample from one place to another one. But I still feel that if the patient is not rapidly deteriorating, you should make all the attempt to have these results in the notes before planning the treatment. We know that PD-L1 expression, which remains the only validated biomarker to potentially select patients for immunotherapy is by no means perfect, because is still open to interpretation by the reporting pathologist. And perhaps you may comment on the potential differences between the clones that you may use. But on the other hand, we still use it on a daily basis, at least to decide between, single agent immunotherapy or combination strategies.
Yeah, thank you. I mean, you're touching an excellent point here, and any biomarker that is, being introduced through clinical trials in a research setting needs to show that it actually performs better than what is currently available. Thinking about biomarkers beyond PD-L1 immunohistochemistry, are there any promising biomarkers where you feel that they might enter clinical stage anytime soon?
And there's a lot of research going on to try and complement PD-L1 expression. A number of trials tried to use tumor mutational burden either on the blood or tissue to better select patients for a given strategy. The results have been somewhat disappointing, in my opinion, because realistically, you can't use TMB to guide management. There's too much variability in terms of cutoff used, in terms of mutations per megabase, different cutoffs. Was the test run on plasma, which is completely different than the tumor? And also it depends on which kind of platform you're using for your TMB assessment. So we can't say that we should use, and in fact it's not routinely recommended by the international guidelines, TMB in clinical practice. There are a number of other biomarkers under investigation, tumor-infiltrating lymphocytes, some genomic signatures looking at T effectors and interferon gamma. There's a very clinical potential predictor for immunotherapy response, which is the LIPI score, which takes into account the neutrophil to lymphocyte ratio and LDH. And pretty much everybody has a full blood count and an LDH at baseline. There are more and more series coming through. Some of them are retrospective, and they give you a hint that if you have a poor LIPI score, you as a patient may derive less benefit to immunotherapy. In particular, this is for single-agent immunotherapy, because the chemotherapy-immunotherapy combination will confound a number of things. So in summary, PD-L1 remains the only potential biomarker for selection for immunotherapy, but there's still a lot that we have to do to validate all these other potential biomarkers which I've mentioned, which remain investigational at present.
My personal, feeling, but that's just a feeling, is that a biomarker, a complex biomarker that somehow interrogates not only the tumor makeup or the genetic underpinnings of the tumor, but also the tumor microenvironment, might support better treatment decisions. But that really has to be shown in a prospective clinical trial, really showing clinical utility. And maybe one comment regarding TMB, I again, fully concur with you. TMB is currently not ready for a clinical setting, and most importantly, has not shown the clinical utility in a prospective clinical trial that you do want to see. And maybe there is also, besides the technical parts that you were mentioning, there is also a biological thing to it, because we are just counting mutations, right? So with microsatellite instability, we are looking at a very specific molecular mechanism giving rise to a number of mutations. So there is also high tumor mutational burden in these patients, but it is a very precise mechanism that gives rise to these new antigens. And maybe just counting mutations in a given tumor is a little bit too simplistic. to fully capture the complexity of the interaction between the tumor and the immune cell. But I would also say that, with all those encouraging points that you were mentioning in terms of what is currently being explored, in addition to an ever-expanding landscape of treatment options, there should be a lot of benefits for patients in the near to longer future. And I think that is very, very encouraging and will be helpful also in a clinical setting. Maybe one additional, question related to clinical parameters that could be used to assess response to immunotherapy. So could you, briefly show the landscape and tell us a little bit about this?
Thank you. So certainly a very important parameter is performance status, and that's a validated prognostic factor for a number of strategies. You will want to give immunotherapy-based strategies to your fit patients, so performance 0 to 1. There is some data now in the PS2 population, but I think PS 0 to 1 is where the vast majority of patients will benefit. From other clinical characteristics point of view, I think there is an increasing body of evidence that show that, for example, if you're considering single-agent immunotherapy, even if there is high PD-L1 expression, patients with never smoking status or light smoking status may derive less benefit compared to chemo-IO combination. And that's also potentially true for female gender compared to men. We don't have a specific biological explanation for the gender diversity, but there's a lot of retrospective data that shows that potentially if you have a female patient, even with high PD-L1 expression, this patient would be best served by the chemo-IO strategy compared to single-agent immunotherapy.
Thank you. From a clinical standpoint, how do you assess response to this therapy? So what are the major measurements that you're using, or tools that you're using, if you will?
Thank you. So from a clinical point of view, let's say you're 4-8 weeks into treatment, the patients may tell you, look, my shortness of breath is improving, my cough is improving, my chest pain is improving, and that makes you think that the treatment may be working as cancer-related symptoms are improving. But from an objective point of view, the only way to assess the response is to repeat imaging. Most of the time is cross-sectional imaging via CT scan. You may also assess the disease via MR, for example, in the brain. But realistically, the scan will tell you, has the cancer reduced in size or been stabilized compared to, is the cancer growing despite the treatment? And that will also be very important to decide if you can carry on with the right approach or you have to stop and change your strategy.
So thank you again for the great discussion. And I'm looking forward to our next session. Thank you.
Hello, my name is Dr. Lisa Holle. I'm an oncology pharmacist and professor of clinical pharmacology at the University of Connecticut and the UConn Health NEAG Comprehensive Cancer Center located in the United States. It's a pleasure to introduce Professor Raffaele Califano, who's a medical oncologist at the Christie and Manchester University Hospital in the United Kingdom, to this conversation with me today. Today, we'll talk about approaches to overcoming resistance to standard of care immunotherapy for patients with metastatic non-small cell lung cancer who do not have driver mutations. We've come a long way with the use of immunotherapy in the treatment of metastatic non-small cell lung cancer. It really has revolutionized the care of our patients without oncologic driver mutations. But we do know that patients can either have primary resistance, meaning that they really don't respond to immunotherapy when used in the first-line setting, or they can acquire resistance over time. There are a number of mechanisms that go into developing that either primary or acquired resistance, and we're really starting to learn about those mechanisms in great detail. I wanted to ask you, Dr. Califano, what types of strategies we already are studying or have in place to overcome these types of resistance?
Thank you. The main strategies are looking at combination of therapeutic approaches. And the first one to be trialed is the combination of PD-1 or PD-L1 blockade plus CTLA-4 with drugs such as nivolumab plus ipilimumab or durvalumab plus tremelimumab, which are now approved options in some healthcare settings. Together with that, another potential approach is to give 2 or more different kind of immune checkpoint inhibitors, which are tackling other checkpoints different than PD-L1 or PD-1 or CTLA-4. And these are, for example, LAG3 inhibitors, TIM3 inhibitors, or also TIGIT. Very interesting from a biological point of view is the potential association or combination of anti-angiogenic agents with immune checkpoint blockade, because we know that, for example, VEGF inhibition can reduce the hypoxia and can also facilitate the migration of the T cells into the tumor and therefore increasing the immune response, or potential combination with PARP inhibition, which is basically DNA damaging agents. So to try and enhance the direct killing of the cancer cells, release of neoantigen, and therefore increase the immune response. And certainly very important, and this is something that we already use in the locally advanced curative setting, is the potential impact and role of combining immunotherapy with radiotherapy, as we know that radiotherapy may potentially manipulate the tumor microenvironment, making the tumor microenvironment more favorable in terms of mounting an immune response. There is some data that if you expose tumors to radiotherapy, you may increase the PD-L1 expression together with other cytokine release, including interferon gamma and so on, which theoretically may promote the immune response. And a clear benefit has been shown in the locally advanced setting post-concurrent chemoradiotherapy with durvalumab, which is now approved all over the world. If you want to focus on the ongoing strategies which remain investigational, certainly the studies evaluating LAG3 blockade with drugs called eftilagimod GMOD alpha plus Pembro, for example, in the TACTI-002 study, or the relativity study looking at relatimab, again, another anti-LAG3 plus nivolumab. These have shown in the early phase setting some interesting results in the pre-treated population, and there are studies ongoing looking at first-line setting or post-chemo IO, so let's say secondary resistance setting. Together with that, we then have the anti-TIGIT compounds. There was a lot of enthusiasm a number of years ago when there were phase 2 studies reporting tiragolumab, for example, which is an anti-TIGIT plus atezolizumab in the non-small cell lung cancer pre-treated population, showing potentially increasing response rate and progression-free survival. The enthusiasm at present with the anti-TIGIT has been dampened a bit by some results in the randomized setting, phase 3, with the addition of tiragolumab plus atezo versus atezolizumab alone, and also disappointing results have been reported in the small cell lung cancer setting. So at present, as a research community, there is a bit less interest in the TIGIT, but I think this doesn't mean that it's not a strategy that works. I don't think we are very good at designing the right study more than anything else. Together with that, another interesting strategy is the targeting TIM3, and again, there's a number of studies ongoing looking at cobolimab, for example, which is a TIM3 inhibitor plus PD-1 inhibition, and again, the combination of the TIM3 plus PD-L1 inhibitor plus chemotherapy in phase 2 to 3 studies, which are now ongoing. And it is very important to see how these studies will read out, because inevitably when you have a small early phase study, there's a lot of selection bias that may influence the outcome of these results. And unfortunately, until you see the phase 3 randomized trials, you can't really bank on these results. I think another important strategy, which is very novel, is the use of bispecific antibodies, which are drugs which are engineered to target two, for example, checkpoint at the time, and potential compounds are MEDI5752, which is anti-PD-1 and anti-CTLA-4 in the same drug, or azacitidine-2936, which is anti-TIGIT plus an anti-PD-1, again, now in phase 2 setting. And kind of compounds that I think are very interesting are also the antibody drug conjugates, which are molecules which are composed by two parts, if you want to make it simple. One is the drug that will bind to the ligand, and then you have a payload which will be released once the drug is in the tumor or attached to the tumor. And usually this is a cytotoxic drug. For example, we have two drugs in phase 2 and 3 development at the moment. One is sacituzumab govitecan, where the payload is these are TROP2 inhibitors, and the other one is datopotamab deruxtecan. They both have in common that they are TROP2 inhibitors, and the payload is a topoisomerase inhibitor, so direct cytotoxic killing of the cells. But again, it's still early days to say if this will be a winning strategy in clinical practice, but lots to be excited about.
And I think the novel targets that we are evaluating in a non-small cell lung cancer setting are also very interesting, being able to target the different checkpoints along with PD-1 and CTLA-4 that we already know are quite effective in non-small cell lung cancer. So I really appreciate you providing that information to us, and hopefully we will be able to overcome resistance that we've seen so far. I'm wondering, in your own practice, with the combination therapies that are already approved, nivolumab, ipilimumab, or durvalumab and tremelimumab, do you use those in practice, and how do you incorporate that into your paradigm of treatment?
So thank you. So that's a very important question. So in the setting where I practice, I don't have any approval in terms of reimbursement in the public healthcare setting for combination of PD-1 or PD-L1 inhibitors plus CTLA-4. So either nivolumab plus ipilimumab or durvalumab plus tremelimumab in the advanced setting. What I think, in principle, is that these are interesting strategies. What is difficult is to find the right patients to give it, because these studies have demonstrated that dual blockade was better than chemotherapy at the time they were designed, which was the standard of care. And the real question is dual blockade better than, let's say, chemotherapy plus an anti-PD-1 or anti-PD-L1? And can I, therefore, justify the addition of the CTLA-4 related adverse events to this strategy? The short answer is we don't know, because most of the studies that were designed, tested against chemotherapy, and that's unfortunately due to the time of the study design. I think there will be a role for some patients to have dual blockade. There are some longer follow-up reports that suggest that you may derive even longer benefit in terms of overall survival. At present, what I find difficult is to decide which are the subgroup of patients from a clinical point of view, but also from a biomarker point of view where I should try it. But again, with more and more trials reporting on this strategy, we should be able to refine it over the next couple of years.
Yeah, those are all excellent points. I think that we have the same sort of conversations within our own practice here. I think the other sort of interesting thing now is trying to figure out, as we treat patients potentially in locally advanced disease with durvalumab, if they present later on with metastatic disease, how does immunotherapy play a role on that? And how do we determine who might have some resistance already to immunotherapy? And should we try some of these emerging regimens if they become effective and available? Do you have any thoughts on that?
And there's a number of questions of what to do at progression. So should we re-challenge these patients with immunotherapy? Yes or no? If yes, what should be your progression-free interval? 6 months, a year? I think is all something that you can pull out of a hat, because nobody knows. And what is also at a biological level going to drive the potential response to what you do next. How can you ascertain that the biology in certain patients will be more favorable to rechallenge compared to not? And on top of that, you need to take into account the potential biomarker status of that tumor.
Well, thank you very much for your expert opinion and all of the great conversation that we had today. And also thanks to the audience for watching the video. You can find out more about immunotherapeutic approaches for the treatment of metastatic non-small cell lung cancer without driver mutations in the other short videos in this activity. Thank you.
Thank you. Hello, everybody. My name is Professor Raffaele Califano. I'm a medical oncologist at the Christie and Manchester University Hospital in Manchester, United Kingdom. I'm joined today by Professor Lisa Holle, who is an oncology pharmacist and professor of clinical pharmacology at the University of Connecticut and USF Health in the United States. And I'm also joined by Mr. Josh Colow, who is an advocate for patients with advanced lung cancer who lives in Woodstock in New York, United States. In this section, we will consider how shared decision-making and the patient's perspective is important in the management of metastatic non-small cell lung cancer. So nowadays, as an oncology team, I think it's very important to involve our patients in the decision-making process when we are deciding on the best plan for this disease. I would like to ask Mr. Colow, what was your personal experience during your treatment planning with your oncologist, please?
Well, I started, after I was diagnosed, I started with my first oncologist. And I was treated with, at that point, for 8 weeks with chemotherapy. And I was very sick at the time. I had been sick for a while before my diagnosis, and with high fevers, and my immune system was not really functioning all that well. And I got an infection from, once I started getting the chemotherapy, I developed an infection, and I was in the hospital for 3 weeks trying to figure out what the infection was. In that time, my caregivers had done a lot of research into immunotherapy. And my first oncologist didn't have a good prognosis for me. And the prognosis was much better with immunotherapy. And so I switched oncologists and went to him having my caregivers tell me everything that they knew about immunotherapy. And the positive, that it would be much more positive, and that I could probably, it was pretty hard. Chemotherapy was very difficult for me. It was very hard. When I got to my second oncologist at that point, he said to me that I should use, because I had a high PD-L1 count, that he recommended I go on to immunotherapy treatment as a first-line treatment. And I was all for it.
How did you find out about immunotherapy as a potential treatment option for you?
One of my caregivers, her occupation was a researcher her whole life, and she does that very well. So I was very sick at the time. I was still very unwell, and I had been started on chemotherapy, and that was really difficult for me. And she just continued to do research about immunotherapy, who the doctors are who were offering it, and what the treatment was, and the potential for it to be better or have better results than chemotherapy. And so she passed on all the information to me. I didn't go reading about it all that much. I just trusted her implicitly. And once I found my oncologist, I trusted him also.
Thank you. So you obviously went to seek a second opinion, which then was able to offer you immunotherapy. Do you feel that at the point of discussion about switching strategy, were you given a good explanation about the potential benefits from one hand, but also the potential adverse events related to this new treatment?
He told me that he thought that it would be better, that I would respond to it, and that there are side effects, and they don't know the side effects beforehand. I had looked them up myself. There seemed to be a long list, and but I was sick, and they were telling me that they could possibly extend my life. So I just listened to my doctor. My oncologist was pretty straightforward with me that the possibility for side effects existed, but that when they did occur, there were ways to deal with them so that I shouldn't concern myself with them. He was trying to not add worry to an already extremely worrisome situation.
Thank you. And I think it's also important from our end as an oncology team to make sure that we explain, the potential adverse events, but we also explain that there is support there to make sure that our patients can cope, or there are ways to mitigate some of the adverse events. And I would like to ask Professor Holle, who's an oncology pharmacist. Lisa, what would you feel is the best way of supporting our patients through the treatment plans from an oncology pharmacist point of view?
Yeah, that's an excellent question. So I think it's really important with immunotherapies to make sure that the patient has a good understanding of what the potential side effects are and how we treat them, because it's very important in the case specifically with immunotherapy that we identify side effects quickly so that we can promptly treat them. That will allow us to continue patients on immunotherapy and get the best efficacy for most of our patients. So I think that in most institutions, there is an effort to educate patients about the side effects, to ensure that they know that they're receiving immunotherapy, and that if they were to go to another institution, for example, if they were admitted to an emergency room at another hospital, that they should convey that they are on immunotherapy so that team is aware of how they might treat any potential side effects. So I wonder, Josh, did you get any information from your healthcare team when you started immunotherapy, such as a wallet card or any handouts that describe the side effects and what you should do?
Yes, I did. I got that handout. I kept it in my wallet. I still do, though I don't need to, or maybe I do. And I was told that if I ever had to go to the emergency room, that I needed to tell them that's what I was doing, that I was on immunotherapy, so they could treat me accordingly.
Great. I think it's really important. I'm glad to hear that you did get that information, because that is very important for the care of our patients. And carrying that card still is also important, because there can be latent side effects or long-term side effects that can happen after a patient finishes immunotherapy that we have to be aware of. I think the other important key is sort of knowing who you can call in your healthcare team if something happens in terms of any sort of side effects. So we commonly talk to our patients about these are all the different potential side effects, but essentially any part of the body can be affected by immune-related adverse events. And so anything that's different, we ask our patients to call us or to message us through their electronic medical record if they use that technology, so that we can discern whether or not it's potentially related to immunotherapy.
We have to educate the patients on the potential adverse events to make sure that they will promptly seek advice. And I always say at the beginning, you're meant to phone us more frequently. There is a learning curve. We want to be bothered. And that's because, as you say, there will be some adverse events which, if left untreated, may escalate very quickly, like the colitis, but also the rash or pneumonitis, a number of them. So we want to know. We do the same. We have a card that says, I'm on immunotherapy, because nowadays immunotherapy is reasonably common across a number of disease groups. But when we started a number of years ago, if you went to ED and you had diarrhea, they would assume you were on chemotherapy. They would give you fluids, a bit of loperamide, and then perhaps they would have discharged you the following day if you were stable. Now, this is going to be a very dangerous approach if you're on immunotherapy. So education of the patients, but also education of the wider team, including the acute teams, is crucial. And I want the patient to say to the admitting doctor in accident emergency, look, this is not chemotherapy, this is immunotherapy. If you have any doubts, the oncology team is on hand. So, is a very important team effort from the caring team, the patients, but also patients will travel. They may end up in a distant hospital. It's very important that there is awareness about the adverse events. And I think, Josh, did you feel that you had a good safety net that allowed you to continue with your treatment in a safe and emotionally comfortable way?
I did. I chose not to. It was more comfortable for me not to go away, to leave the country, or even to travel a lot. And I had access all the time to the nurses. If I called the answering service, I would either get a call from a nurse, or I think in the beginning I even had the number of my oncologist, his personal number, because there was a lot of fear involved. I didn't really understand. I didn't understand a lot of things that were happening to me, certain fevers and things like that. So I would ask him questions. So I felt like I was completely safe. That's really the reality.
And I think that's very important when you're going through treatment. I think we've had a very nice discussion around the topic of the involvement of the patients in the decision-making process. What we have learned is that we as clinicians and oncology team have to educate about the potential adverse events. There needs to be ways of supporting the patients, either in an active way, but also via literature or handouts, so that if there is involvement of a wider team, patients are treated in the best possible way to mitigate these adverse events. I would like to thank Mr. Colow for the participation and Professor Holle. You can find out about more immunotherapy approaches for the treatment of metastatic or advanced non-small cell lung cancer without driver mutation in other short videos in this activity. Thank you very much.